Namaste and good morning. I, Mahima Kapoor, researcher and assistant editor at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, नई दिल्ली, welcome you all to the IMPRI #Web Policy Talk. Today, we have gathered for a talk under the State of Development Discourses, #Cohesive Development, with Professor A. Venkat Raman on private sector engagement and public-private partnership in health service delivery in India. This deliberation is being organized by the IMPRI Center for Human Dignity and Development and CDECS Jaipur. I feel privileged to introduce the moderator for the session, Professor Sunil Ray. Sir is the former director at A.N. Sinha Institute of Social Studies, Patna, and an advisor at CDECS and IMPRI. Professor Ray has 35 years of experience in research and teaching in the field of environmental economics, political economy of development, rural development, and institutional economics. He was part of the review mission team of the European Commission and has worked on several consulting assignments with the World Bank and other international organizations. His papers have been published extensively in reputed national and international journals. He has authored several books, including Industrial Growth and Protection in India, Natural Resources, Organization and Technology Linkages, Agricultural Services in the Poor, Management of Natural Resources, Institutions for Sustainable Livelihood, and Theorizing Cohesive Development and Alternative Paradigm. Welcome, sir. I am honored to introduce the speaker, Professor A. Venkat Raman. Sir teaches HRD and Health Policy at the Faculty of Management Studies, University of Delhi. He is passionate about exploring public-private partnership options to improve equitable access to quality healthcare services for the poor. He is actively engaged in providing technical support to many bilateral and multilateral development partners, including the World Bank and WHO, and many governments on private sector engagement for countries in Asia, Africa, and Eastern Mediterranean region. Recently, he led the development of a partnership guidance document on performance-based contracting of private providers in the National TB Elimination Program, Government of India. He has several research publications, including a pioneering book on public-private partnership in healthcare in India, Lessons for Developing Countries. Sir is the recipient of several awards and fellowships, notably Robert McNamara Fellowship, the World Bank, Ronald Coles Fellowship, UC Berkeley, and International Senior Research Fellowship, Erasmus University. We welcome you, sir. We are fortunate to have Dr. Narendra Gupta and Dr. Swati Sawant Rane as the discussants for the session. Dr. Narendra Gupta is the advisor at Prayas, Chittorgarh. Welcome, sir. Dr. Swati Sawant Rane is the founder at SevaShakti Healthcare Consulting and the Vice President, Clinical Nursing Research Society. We welcome you, ma'am. Now I invite Professor Ray to take the proceedings further, and we look forward to learning from our esteemed gathering. Thank you.
Sunil, please unmute yourself. Yeah. So bottom.
Okay.
Yes.
Are you able to hear me now?
We can now. Yes.
Yeah, that's really. Thank you so much, Mahima, for your very nice introduction. Let me tell you, I'm feeling I'm feeling extremely privileged to be in the midst of very learned people, academics, as well as those who have been practicing medicine in the field with the people. This is something which is experimental at my level, because IMPRI, under the leadership of Dr. Arjun, pushed me to really reflect on, is an opportunity for me to reflect upon something which is I never thought that I would be able to do. And being an economist by training and having been working on cohesive development of the discourse for considerable amount of time, having been inspired by the sociology, political science, economics, biological science, and also the physics, and a kind of interdisciplinary understanding that I had on cohesive development that I developed. And fortunately, IMPRI has taken the full initiative to really invite large number of people all over the country and the world to reflect on this cohesive development within the parameters given by these disciplines I talked about. But the parameters that Professor Venkat Raman is going to speak on, and being what is called substantiated or being expanded by the discussant, the learned discussant, both Dr. Swati, Sawant, Rane, and both of them, Dr. Gupta, both of them, as I know, especially, of course, Dr. Swati, Rane, I do not know personally, but I heard about her and I've been seeing the biodata, and also I feel extremely privileged. And Dr. Narendra Gupta, whom I know personally for last several decades, I'm just the opportunity to just share with you that not only he is a great physician, but also he has been working for the tribals for years. He is very much in touch with the people. And not only the tribals, he goes beyond. And also he developed his own perspective as well, which is something very important for me really to look into. And as I could see Dr. Swati's, biodata, and I heard from IMPRI, is something which is fascinating for us to really put them together. And with the intellectual inputs of Professor and experience of Professor Venkat Raman, who is going to initiate the dialogue or discussion, is a kind of thing which inspires me to think much in a different way as to how do we really conceive cohesive development given the parameters that I'm going to really churn out from the discussion that is going to take place today. It's a challenge. And IMPRI has forced me to face this kind of a challenge. And I certainly am sure with the help of some of you, I'll be able to succeed to how really I incorporate the elements of change from this angle that I have been talking about in the perspective of cohesive development discourse. Now, given this kind of, let me tell you very briefly about this Professor Venkat Raman, this forum, Dr. Swati and Dr. Gupta. This IMPRI, to the best of my understanding and knowledge, I've been working all over the country and of course visited several countries of the world. But IMPRI is something here today, has been experimenting for the last few years, trying to experiment with the new ideas. That's few minutes ago, I was talking to Dr. Arjun. Look, we always brand somebody with some ideology, brand somebody with this particular school of thought, nothing wrong in that. But what is missing in the whole of this process is that the human element. Sometimes the branding overpowers the human element that gets missed out. And it is that if you start from the human element or the humanism or the human being and go to the any brand which you like to be, is fantastic. I think that is something which is missing. That needs to be brought to the center of the discourse and to see where do you stand. That is something which needs to be really talked about. And IMPRI is trying to really bring that particular part in the whole of discourse and trying to see through whether you are right or wrong and how far you are right or how far you are wrong. There is nothing called absolutely right and absolutely wrong. It's always a right, wrong, a relative. It is something which is called, is a very important thing for us to know that this, it's the social science and also the human life. Nothing is something absolute, and especially when you talk about the relativity, and from that point of view, find this with something which is relatively better, relative worse off, and so on and so forth. So given that kind of a thing, it is IMPRI has opened up this forum, and this forum, whether it's economics or sociologist or the political scientist or demographer or all social sciences, they have been coming all over the world and making the presentation. And the best part of the whole thing, this IMPRI team, they are documenting the entire presentation and will be bringing out a volume very soon based on the presentation, based on the discussions, comments, perspective, and so on and so forth. So that is something experimental in certain sense. And perhaps in India, we do not see something which is open in this commitment, in this kind of a commitment. And it is an opportunity for some of us to really place forward our ideas, understanding, keeping the whole human elements at the center of the discourse. That is something which is very unique of this particular forum, which is being, and I'm very fortunate. I feel privileged. I also am thankful, grateful to IMPRI. They have given me an opportunity to initiate this kind of a forum, to see that this particular series, initiate this kind of a series. That's something which really finally ends up with some great amount of success. It's kind of what is called Professor Venkat, Dr. Swati, and Dr. Gupta. This is something, challenging the paradigm, challenging the existing paradigm. It challenges the existing paradigm. And we know the existing paradigm has failed miserably and varieties of ways. I do not want to get into evaluation of good, bad, and of that paradigm. But it is a fact now. It's failed miserably. Just imagine if you have 73% of the population in India today after 75 years of independence. I do not want to drag myself into politics. Who is to be blamed? Who is not to be blamed? But only think that if 73% of the population will lack primary health care center in the rural areas, just imagine. After 75 years, Professor Venkat Raman, you have got, in your paper, you also mentioned somewhere I could see. At the same time, 75% the healthcare infrastructure is 74% of the doctors are living in the urban areas. Look at the urban-rural divide. Let us not talk about economics. Let us not talk about anything. Is a primary health care. Is the health which is something, is a human right. Is a human right. A state when originated, it's supposed to commit it. The state, not the government, but the state as an institution. It's when it originated, we go into the theory of origin. It has its basic commitment to the human rights, which cannot be defied. And health and education, primarily the human right. If the state is responsible to provide this human right, come what may. And it is this state of affairs now after 75 years of independence, where 73% of the rural population is totally outside the primary healthcare center. It's unspeakable. And then again, WHO criteria of 1,000 population per one doctor. We have got one doctor per 1,445 population. This is the state of affairs today even. Now, where do you stand? At the same time, you have this kind of efforts, public-private partnership to erase this kind of a problem, to reduce the intensity of this problem and all that. But some studies at the international level as well as the Indian level, they show that again, there could be success stories here or there. But at the same time, the stories are different in many cases. It lacks transparency, is embedded with the corruption, corrupt practices. Is also the public funds get transferred to the private when its partnership talks about. And at the same time, what Professor Venkat Raman in his abstract has pointed out very nicely and clearly and very convincingly is that when it goes to the private sector, it's people, especially those out of pocket money they spend, and is something which is exorbitant rate of the medicine rate of the service charges. Now, how is it possible for a country like India, where 75 or 73% of the population, not this urban or rural healthcare, after the total population of 73-75%, they're struggling to survive. How is it possible for you to really? It's a great challenge. Now, on the one hand, I do see a point personally. There is a need for partnership for the private and private. You need to define what do you mean by private. Is it basically MNCs, big manufacturing, or a small person, a doctor who is practicing in the village, also a private sector? Now we need to really enhance the definition of private sector, so see that there's something which really happens in a better manner, to see that the healthcare is something which is primarily human rights, is not neglected at all. Now, in the name of the collaboration or the partnership, no partnership really fits into the whole framework of cohesiveness if it really is subject to exploitation by the private sector, by the public. It's not the subsumption, it is a partner in the real sense that will satisfy what cohesive development program. With these very few words, I'm sorry that I've spoken by not necessarily because this is something which I would like to enlighten myself by some of you and Professor Venkat Raman's lectures and all that, and all of your contribution. I'm thankful to all of you. Now, may I request with these very few words, because this is the kind of a challenge. And at the same time, I do not want to hear what is being talked about. Please ask new questions. If you have new questions, you have new answers. If you have old questions, you have old answers. And we are bored of old answers. We are bored of old questions. Now, if it is not happening, you please ask me why it is not happening. Let's get into the critical aspect of it. Who is to be blamed? Yes, you must be accountable. And that is necessary for us to really ask real questions. And if we do not ask the real new questions, we will not get the new answer. Sorry. Thank you so much. I now invite Professor Venkat Raman to enlighten us on this subject, to see that we are able to go forward with a band of logics which really renovate the whole understanding of cohesive development in the context of India. Thank you so much. Professor Venkat Raman.
Thank you so much, Professor Ray, and thank you so much, Arjun, Mahima, and I am looking forward to the interaction from Dr. Swati and Professor Dr. Gupta. First of all, I do not know whether I deserve the kind of introduction you gave, Mahima. Perhaps I was guilty of giving you that kind of write-up to speak about. But nevertheless, I would, first of all, after thanking the organizers, IMPRI, for giving me an opportunity to share my thoughts about this. This is a topic that has been close to my heart for the last 20 years. I've been trying to do a lot of field research on this, and then based on my own experiments, or if I were to say pilot, experiences or lessons from different parts of the country as well as outside the country. Now I share some of my thoughts about it, because 30 minutes is not an ideal time, but nevertheless, I will try to say a few things that maybe may trigger some kind of a debatable issues here. First of all, let me clarify that why this topic is quite, it's a bit of private sector engagement and public-private partnership. I'll try to clarify this thought, because theoretically speaking or technically speaking, these two are two different domains. But then we are not looking at the Puritan point of view. We are looking at it as simple as possible. Number two, I also want to really put down certain caveats before I begin to make this presentation. Primarily, the reason for making this presentation is to keep the audience engaged. I don't want to be sounding monologue by only giving a talk without any visuals. My caveat is that I am only looking at the PSC or private sector engagement and PPP as one of the policy options, not to supplant or not to substitute the public sector responsibility or the government's responsibility towards extending the healthcare services to the population. I'm looking at it only as a kind of a complementary to the existing, kind of effort by the government. And therefore, please keep in mind that my presentation is focused on what are the various models of engagement and what have we done in the last several, maybe couple of decades in terms of the private sector engagement, and what have been the lessons and what are the kind of issues that we need to confront in order to really make private sector engagement more successful or more productive or efficient. I don't want to speak more on this because all of you who are erudite here, who have great intellectual, curiosity, would know that the health sector in India has been at a dismal performance, but particularly the public sector. If you were to really look at the private sector, it's a pretty unregulated in terms of the kind of rationality of services, as well as in terms of the cost, in terms of its distribution, in terms of its clinical efficacy, etc. One can keep talking about it till the cows come home. So it's not something that I want to spend more time on this. But what I am more keen about is that while the public health sector or the government health facilities are either grossly underused or not sought by the public, the evidence is very clear. Let me try to show you the evidence here. Why we are talking or why we are making the private sector as a very important element in our health sector or in the health system is this. This is the 3 decades of our population seeking healthcare from the private sector. This, despite the investment from NRHM, despite the investment that has gone in the last 3 decades, starting from the 1995 NSSO data set till 2014 data sets, you see that a gradual increase in the urban areas in terms of the proportion of people seeking inpatient services. Outpatient is another different story. It's close to 80% there. But the hospitalization alone, you can see that kind of a growth. It is not surprising that you see even the rural areas, people are going to the private sector. Again, as I said, that despite the fact that we have invested close to 120,000 crores into NRHM, starting from somewhere in 2005 till 2012-14, and yet the proportion of people going to the private sector continue to remain the same. And therefore, private sector has become an indispensable caregiver in Indian healthcare system. So we can condemn them, but we cannot ignore them. And because the choice of population seem to be more or less decisive in terms of where they wish to go and seek services. What are the reasons behind this? Again, we can debate. I think one of the most important element here is that despite the element of investment by various states or governments across the country, somehow the people are not choosing to go to the public sector. Maybe due to, if you go to any primary health center across any parts of the country, whether it is Madhya Pradesh or Rajasthan or UP or Bihar, you would know that either the doctors are absent or the medicines are not there. I come from a village and I know very well that we don't go to the healthcare, we don't automatically seek healthcare if we fall sick. It's only when a patient is unable to stand up, that's when they go to the health center, and that's when they see that there is no doctor or nurse or medicine in the public health facility. Then they try optimizing their time by going to a close by, individual practitioner. And that's how slowly people have transited from or transitioned from the public sector faith towards the private sector. Now, seeking private sector services, it is also very critical to know, when I seek services from the private sector, who is paying for my services? And this again comes from the NSSO data, that you will be surprised to see that India spends on an average close to 5% of GDP on healthcare, expenditure. But close to 4% of this is out of pocket. That's almost 80% of the health seeking expenditure is out of pocket, household out of pocket expenses. It's also surprising that the two contrasting places, Kerala and Bihar, gives you an indication that despite the best of the public sector provision of services in Kerala, despite the less desirable public health services in Bihar, the out-of-pocket expenses seem to be somewhat close to one another. This is quite surprise. I will perhaps, when there is a debate, we will discuss about this, why this happens. So the foundation that I'm trying to lay is that a large proportion of India's population is seeking care from the private sector. And while seeking care from the private sector, they are paying out of pocket. And therefore, it is imperative for the government to protect them from paying out of pocket, financial protection in terms of avoiding their catastrophic health expenses, avoiding further, pauperization, if I were to use a better word for that, not better word for that. Further, economic consequences. It is up to the government to really protect them from being, getting into the impoverishment. And therefore, you have RSVY in the past. Now you have, Ayushman Bharat. Hopefully, this will pave the way for protecting the poor from paying out of pocket. There are other reasons why we need to engage the private sector. India's health infrastructure, as Professor Sunil mentioned about, that the 73% of rural population do not have primary healthcare facilities. Just to take an example that he also mentioned, according to WHO, we are supposed to have 1 doctor per 1,000 population. But compare it with perhaps China, 2.8 doctors per 1,000 population. Even if we were to move towards 1 per 1,000 population, we require another 250,000 doctors, or maybe 200,000 doctors as of today, which means that we need to have a lot of medical colleges to really invest into. That's number one. Number two, the number of hospital beds in India is also very abysmal. For example, India has something like about 0.8 per 1,000 population, compared with around 4.8 in China. Because I'm making this comparison not because of political differentiation, but in terms of population ratio. Right? That's the best comparable that we can think about. So if we were to really look at the number of hospital beds in India required, according to Bain Capital, there is a publication that they came out with, which mentioned that India would require almost 2.8 million additional beds. And I'm sure Swati and Dr. Gupta would know this, that in order to create 1 hospital bed, right, how much investment is needed, ranging from somewhere between 40 lakhs to 1 crore per bed. And where are we going to get that kind of an investment when the government is still spendthrifty in terms of allocating only between 1 to 1.2% of GDP for healthcare services? So the investment must be mobilized through the private sector. That's the thought here. The second is that if you can look at any of the rural health statistics as of today, you will find that most community health centers in India, when I talk about community health center, I'm sure all of you would know that this is a population-based kind of a thing, where primary health center for every 30,000 population and a community health center for 150,000 population. 80% in every community health center, there are supposed to be 4 specialists. All right, a pediatrician, a general surgeon, an obstetrician, gynecologist, and a general surgeon. In 80% of community health centers, the specialists are missing, which means that a large proportion of people have to really travel up to the district headquarters, or they will have to seek services from the private. And many of the district hospitals, including regional level hospitals, do not have super specialty services, or forget about the quaternary care, but the super specialty services. And therefore, people have to really go to the private. There was a time when people tend to think that why we are investing in cardiothoracic units in public hospitals, as if to say that the poor do not have heart complications. I remember growing up in, listening to this for the last 25, 30 years, that spending too much money on to the cardiothoracic unit could improve the primary health care. That's where the catastrophic health expenditure needs to be thought through. And finally, the third logic for engaging the private sector, I had already explained that a large proportion of people spend out-of-pocket expenses, and therefore it is up to the government to really protect them from paying out-of-pocket. Let's look at some of the foundations on why we talk about the public-private partnership or private sector engagement. This comes to a fundamental, understanding that who will be financing it, health services, and who will deliver the service. I take this framework from my good friend Gerald Bloom from Sussex. In 2001, he came up with this framework. And in this framework, you see that the highlighted portion is the only part that we are exploring as PSC or PPP. We are not in any way saying that the public hospitals will vanish, or neither we are saying that the private hospitals are going to vanish. We are only trying to find out if there is a possibility of public financing, private delivery, assuming hypothetically that the private sector delivery is more efficient, more quality oriented, and more efficacious. Remember, these are hypothesized benefits. There are evidence that are emerging slowly, but then this is not something that we will be conclusively be able to say. We'll park that aside for the time. Now comes the reason why I use this framework of, or rather my title as, for private sector engagement and the public-private partnership. Private sector engagement is a broader, holistic approach, whereas public-private partnership tends to focus mostly on certain kind of an integrated model wherein the private sector is allowed to build, finance, operate, and transfer, as in the case of any other infrastructure projects on PPP mode. I repeat that the PPP models are much more transactional in nature, wherein the investment opportunities are greater and the risk apportionment between the public sector, government, and the private sector takes a greater risk compared to the public sector. These are professional, legally binding contracts, and they are invariably long-term in nature, anywhere from 20 years to 35 years. So whenever we talk about infrastructure-oriented PPPs, either in terms of building hospitals or the UK model of private financing initiative, or giving land in exchange for some kind of a free bed, etc., or any kind of a joint venture, these are what Puritans would call it as PPP. Healthcare is not like a road, making a road or an airport. Healthcare is much more complex because service delivery is the most important objective, not building a hospital. And therefore, when we talk about private sector engagement, it encompasses all possible combinations. For example, the TB control program, when we looked at it has a chain of services needed to be delivered to a patient, starting from screening till the treatment completion after 6 months or 8 months. There is a large number of supportive services that needs to go in. So you cannot consider this as a PPP, but more of a PSE, because it's a private sector engagement. Maybe some NGOs will come in play, or maybe some hospitals will come into play. So that's why I have used this broader framework of PSE and PPP being part and parcel of it. I hope that makes the explanation to the title, lengthier title, little more understandable. The second bunch of reasons why private sector engagement is a possibility is in terms of if there are several primary health centers. For example, in India, 25% of primary health centers are considered to be either without a medical doctor or underused or in dilapidated condition. Can we think about giving or allowing an NGO to run primary health center? This is not a new idea. This is an idea that has been in operation since 1998, starting from Karnataka. I'll talk about some of these models as we go further. Co-location, for example, some of you come from different cities. You will know that, for example, in SMS Hospital in Jaipur, they have Vardhaman radio imagery services, which is basically providing CT scan, MRI, and even linear accelerator facility within SMS Hospital. And that's what we call it as co-location. So some of these co-locating models are considered as management contracts. Then comes the purpose for which the private sector to be engaged is through the financial protection, for the purposes of financial protection, wherein you talk about demand side financing. For example, somebody who's familiar to Gujarat would know that Chiranjeevi scheme was something like a demand side financing. Asking a doctor to come into the public health facility and giving them some kind of a remuneration for per capita services. For example, if I am a private doctor, I can go into a public facility and I can deliver babies, birth deliveries, attend to the birth deliveries. I can be paid per case, something like $1,500 or maybe 2,000 rupees. That's called the supply side finance. And there are various models of grant in aid. We also know that health insurance, the social health insurance in India, the PMJY, is something that is taking roots now. It would have its own, what we call it as teething problems, but it is surely going to be perhaps a game changer. And as many people would say that this is still in the very inceptional stage. Of course, it is an inceptional stage, and we need to keep hoping that this will become a universal health coverage at some point of time for our population. I am really hopeful about the Ayushman Bharat. There are other possible engagement options. For example, whether it is human resource supply or drug research that we saw in vaccine delivery. These are other options that are available. I'll skip this part for the time's sake. There are some of these examples that for this, the slide that you see here, these are all infrastructure related PPPs. The one at the top left is the Doon Hospital wherein you will see that it is the Fortis Hospital which has built up a cardiothoracic unit within the hospital premise. So it's a kind of what we might call it as a co-location. But it is a separate ward and a separate facility. The second, at the bottom on the left, you will see that this is a municipal general hospital in Mumbai. This building was rebuilt under CSR funds. The ownership is with the municipal corporation, but the hospital is operated by Brahma Kumaris. So you have an NGO also capable of running an entire hospital. Then you have top right, you will see this is the Apollo Medical College in Chittorgarh in Andhra Pradesh. And this is a complete built and over a long-term contract, the medical college being attached to a district hospital. What you see at the bottom is the Adani Medical College, which is there in Gujarat. One of the, again, earliest models of PPP in medical education. Of course, Sikkim Manipal will say that they were the first one to be part of the PPP. No dispute on that too. These are some of the management contract oriented, PPPs or private sector engagement. The one on the top left is the very first primary health center run by Karuna Trust in Karnataka in a tribal location. This was starting from 1999. These were documented early by me in 2004, 2005. At the bottom left, what you see is the kind of a specialty hospital. It's called Rajiv Gandhi Super Speciality Hospital in a district called Raichur in Karnataka. This was also given to Apollo to manage for 10 years to begin with. Remember, this was built by the government, but handed over to the Apollo Hospital to run it and provide services to the population, because the government could not deploy their own doctors there, who could not really remain there in such a backward area. The one that you see in the middle is in the Sundarbans, where it's a boat-based clinic. This is a boat, donated by the French authors, Dominique Lepari and forget the second author. I'm sorry, the Freedom at Midnight, the authors. The boat was donated by them, but the doctors were deployed by an NGO, and the government gives them certain kind of a grant in aid to have this mobile boat-based clinic. What you see on the top right corner is a community health center in Himmatnagar in Shamlaji in Gujarat, and this is managed by Seva Trust, not the Seva Rural, Seva Trust, which is a different group. What you see at the bottom is in Uttarakhand, right side. What you see is Uttarakhand, where a mobile medical unit which goes into hilly terrain and camps puts up camp every week, so to say. It started when I documented it once in a fortnight, but later on got expanded it to once in a week. Again, in a hilly terrain, there is no access to the static facilities, so mobile facilities are the most ideal way to reach out to the population. What you see here is a combination of variety of social health insurance models in India. Samba voucher scheme that was there earlier in Uttar Pradesh and Uttarakhand. What you see at the bottom is a Yashashwini scheme in Karnataka. What you see in the middle, top and bottom, is an RSBY followed by the PMJY. What you see on the right side at the top is a Chiranjeevi scheme in Gujarat, and the bottom is Rajiv Arogyashri scheme in Andhra Pradesh, undivided Andhra Pradesh, now both in Telangana. These are other models, whether they are telemedicine, whether they are ambulance, whether they are dialysis, whether they are laboratory services, whether they are CT scan, MRI in SMS hospital. These are a wide spectrum of possible combinations that one can think about. In overall sense, globally, PPP has been growing in some areas, some geographical areas, and have become more mature in certain other areas. For example, Australia and North America are considered to have more mature and continuing PPP markets, whereas in many of the European continents, there is the maturity is high, but there is a slight decline in the PPP opportunities. India is seen as a high growth oriented market for PPP. So is China and many other Southeast Asian countries, and also some parts of Latin America. The entire African continent is fertile for more and more PPP options there. Just to give the benefits of PPP or PSC in primary care, I am just looking at it from, there are many benefits that I can document, but just for the sake of time, I'm just giving you something that you can consider to be outlandish. In rural Patna, there was an experiment carried out between 2012 or rather 13 till 2017, wherein private sector was mobilized through an NGO to look after the TB control or TB program patients. What you see on the left side is the Patna rural experiment. The public sector alone was able to notify on an average somewhere around 70 population or 70 people afflicted with TB per lakh population. This was the past trend. Starting from 2013, 80 people detected of TB per lakh was the public sector government notification record. From 2013 till 2016, private sector got mobilized through this NGO called World Health Partners. Now, can you imagine the proportion of TB cases that got notified through the private sector mobilization? Look at it. 296, 6 times, close to 6 times more of TB patients got recorded and their treatment started commenced. And that is the impact of when you bring in the private sector on board. I'm giving this as an example of how far the private sector mobilization can be effective. The second example that I would like to give is in terms of Corona Trust. If you allow a rural primary health center to be managed by an NGO with the same kind of a budget that is allocated to the primary health center by the government. Remember when Dr. Sudarshan took over this particular primary health center, the government gave him only 75% of the allocated budget that was earmarked in the government budget for a primary health center. Let's say if it is 20 lakhs per annum is the budget earmarked for a primary health center, the initial contract allowed only 15 lakhs to be given to the NGO to manage the primary health center. Later on, it got into 90%, and Arunachal Pradesh gave Corona Trust 100%. Dr. Narendra Gupta would know this. I am sure he will be highlighting some part of it. But look at the institutional delivery. Look at the infant mortality. The difference between the Corona Trust-based management of the primary health center and Karnataka rural in general by the public health system. These are some examples. Now, what are the possible challenges? Do I have 5 more minutes?
Yes, please, sir.
Okay. The first thing is that there is a general sense of mistrust not only between the government and the private sector, but also in the civil society and the population at large. The moment we talk about public-private partnership or private sector engagement, there is a general suspicion that the government is selling its silverware. But that's the beginning of the problem. Okay. The second most problematic issue is that almost everybody interprets the public-private partnership in their own perspective. This is this proverbial, visually, challenge the people, feeling the public-private partnership. So in a situation like this, there is a great deal of possibility of interpretation, which are not necessarily conducive to the obligations of both the partners. Because even if you give a laundry services in a hospital to a private partner or a private agency, that's also considered as a public-private partnership. The reason why I mention this is that if Swati was involved in any PPP, she would know that one of the most troublesome private sector engagement problem is the timely payment of the dues to the private provider. I've known situations where people have not been paid for a year, 15 months in some cases. The government takes the services, people benefit the services, but the payment is not done in time. What do you do when such kind of delays occur? Because the reason why I am referring at this particular point here is that unless you are committed to the principles of partnership, you cannot succeed in making the partnerships to be benefiting the population. Imagine if a private partner says that I am not getting my revenue and therefore I am going to close the services. Who is going to suffer? Private sector will find another place to go and do their business. It is the population or the citizens who will suffer because the discontinuity of services that the government was unable to provide on its own. So it's important to understand the nuances of a contract and the contract obligations to be fulfilled on both the sides. And that's why I mentioned about this, because people tend to interpret PPP in a different manner, and one need to be very careful about interpretation of this. And finally, I just want to mention what are the reasons why PPP is still not a very good story in Indian countries. The first is we all know that the private sector is predominant provider of services in the country, and yet we have very little information about the private sector in the country. There is no database about how many private providers are there, what their bed capacities are, what their installed facilities or their technology available, etc. We don't know even the cost. I'll just give an example. Within Delhi, you walk into one of the streets, you will find that one hospital charges something like, let's say, hypothetically, 100 rupees for an X-ray. 10 meters away or 100 meters away, another hospital will charge you 150. What is the reason? I have no idea. Perhaps we need to think about it. And not only that, but also, if you go in the morning, you will be charged 100 rupees. If you go in the afternoon, you will be charged 75 rupees. So the point I'm trying to say is that there is a lot more dynamics of private sector that we still do not have a clear idea about. The second most important problem is that the political and administrative lack of political and administrative commitment. Politicians say different things at a different point of time. Without naming any particular political group, I know of one of the largest provinces in India where the health minister said that we would explore public-private partnership and asked the private sector to meet him or her. I'm not again mentioning the gender. And when the private sector was interested to meet the minister, they would go to a five-star hotel, adjourn into a room and asking, the private sector would be asked, Mera commission kitna milega? And the same,
absolutely.
And the same, minister would go into a public forum in a public meeting next to that private sector hospital and say that private wale hamare koon choose rahe hain. I am using the same language that he used. All right, so you can understand how it's not only about the politicians, it's also about the bureaucrats. Bureaucrats do not let go of the control. And therefore, health ministries are very rarely enthusiastic about PPP. The third, of course, I mentioned already is the hostility, lack of trust. This is quite an ecosystem that we have. Anything, remember, this comes from our own, Dilip Kumar movie onwards, that whenever we talk about, the popular movies have always portrayed the private sector as a poon chusne wala. So anything that we talk about private sector, there is this cultural myopic perspective that the private sector is not good. So that's why the reason for hostility. We also know that there are lack of a policy or a legal or an institutional framework for engaging the private sector. Forget about engaging the private sector towards the private sector, right? So there are 29 states in India. In 2017, I did a little landscaping of how many of these states and union territories have any kind of a policy towards the private health sector. And I found only 4 out of 29 states and union territories, plus the union territories, have some notings on private sector in their overall health, departmental policy. We don't have, except for 2 states, remaining states do not have any kind of Directorate of Health Services having a private engagement nodal officer. So tomorrow, if Swati wants to go and talk to somebody in Rajasthan government doesn't have a nodal officer towards engaging or talking to the private. The payments delay is due to lack of a fiscal space for private sector engagement. The government's budget do not have a single line item for private sector engagement, and therefore, year end they try to look for some kind of money here and there, and they pay up the private. Then the issue of contract design and monitoring, and these are more technical in nature, and there are pursuit of uniformity where there is a problem of contextuality getting lost. What is successful in one state is not successful in another state, and therefore you cannot just replicate something from one state to another. Finally, I just want to conclude here, just before this, as a penultimate slide. We need to understand that working the private sector is inevitable in Indian context. We are getting to know more and more evidence, including my own studies, that the private sector engagement reduces the out-of-pocket expenses. Private sector engagement is not privatization. And we need to have institutional capacity to optimize the benefits of the private sector engagement. And while you explore the private sector engagement, focus also on strengthening the public sector ability to deliver service. The way forward is that we need to have private sector specific policy. This is something that I keep advocating. Just as I speak, we are just working for Bangladesh, and in Bangladesh, we are also proposing very similar kind of, strategy. Create institutional systems and build capacity. Provide a better ecosystem for private sector engagement. Don't allow only a certain kind of vested interest to come forward and create that. Create a larger, dialogue to reflect upon the engagement of the private sector. Effective licensing and regulation is the foundation on which private sector engagement needs to happen. Unfortunately, that is the backstage kind of a neglected area in India. Accreditation and physical standards are getting more and more every day in India. Therefore, there is a lot more insurance-based, purchasing that is possible based on this. If any of you are interested, please you can follow up any one of these where I have contributed in this. Thank you so much once again for the opportunity. I'm sorry if I took a little more time than I should have. I think 30 minutes was the time, but I guess I exceeded by at least 10 minutes.
Yeah. Thank you. Thank you, Professor Venkat Raman. Thank you so much. Very rich deliberation. I wish to hear you more and more. It's something extraordinarily enlightening for me. And number of issues that you have raised. Now, there are number of questions rather not to be answered by you. I have not answered to the extent that you want, but it's being left to the people to decide as to how to go about and all that. That is what exactly the approach should be, and I really find it very interesting and idealistic. At the same time, also, it has tremendous amount of grounding your deliberation. I wish that the entire text could be, at some stage, could be delivered to the IMPRI so that they will be able to really help in printing the entire, maybe that some changes you would like to make and all that. And that could be very useful, very, very useful today. Anyway, we'll discuss more, but I would like to, I think every one of us now eagerly waiting to hear the discussant comments, observations, and their perspective. And may I request now Dr. Swati Rane to reflect on what Professor Venkat Raman has spoken about. Is a very rich deliberation, Professor. I thank you so much for having done within a very short span of time. He has spoken many things, and by implications, perhaps one can build up many logics, many understanding, many reasoning, and something which is very important for us to learn about. Now, may I request Dr. Rane to reflect on what Professor Venkat Raman has spoken about. Thank you so much. Thank you, Professor Venkat Raman.
Professor.
Dr. Rane, yes.
Thank you, Professor Venkat Raman and Sunil Ray, sir. Thank you so much for giving me this opportunity. So let me greet everybody. A very good morning, dear friends. And I'm honored to be part of this exciting and insightful session organized by Impact and Policy Research Institute. Let me open my discussion with a quote from former Prime Minister of Britain, Benjamin Disraeli. He said that the health of people is the foundation on which all their happiness and all their powers as a state depend. So when we say health, so health is an element, I feel, which is a part of us. So today, if I'm having headache, I'm not healthy, I will not be able to do this discussion. Okay, so being healthy is very important. And I think in my small experience of around 20-25 years in healthcare, being a nurse, my basic background, I'm a graduate nurse from SNDT, Mumbai. And later on, I was in critical care units, taking care of cardiac cases. And there is I realized, that something is missing in the whole healthcare system. Okay. And then I ventured into doing my master's in hospital administration from TISS. And there, when I understood the facilities, what are the services, what is healthcare system, what is needed to be healthy, I felt somewhere during my PhD, when I did my PhD in hospital administration, that was how the physical environment and the working environment impacts the nurses to deliver a better care. And during that evolution of mine, I realized that we have missed the bus when we are talking about healthcare systems. We are trying to treat a person. We are not trying to make them healthy. Okay? Because for being healthy, I don't need a doctor, to be very frank. What I need is good food, good water, good environment, happy environment, sunlight, a place where it is greenery, there is exercise, good food which is free of toxins, okay, and good environment with good friends. Okay. And if you have that, definitely you will not need a doctor. And if you see, look back, my grandfathers, I don't think they have even visited a primary health center. Okay, or my grandmom, who has delivered around 11 children, she visited any healthcare center to deliver the children because they were so happy and contented in that atmosphere. But now, if you see in past 30, 40 years, even if a child sneezes, the mother will first take him to the doctor. So the whole narrative has changed, okay, from being healthy to having the best facilities or attending to the best facilities. So even if you want to buy a house, you will buy a house which is near to a 5-star hospital. Okay, you will not buy a house where there is good garden. So the whole this narrative has changed, and somewhere the whole concept of healthcare industry, from making or giving facilities, we have become more of a commercial angle where venture capitalists are coming in, because there is no regulatory board, as Professor Venkat Raman has very, very rightly said, that there is the challenge is there is no regulation. He showed the elephant where everybody is visioning health or system as per his requirement and need. And unfortunately, if you really see health, the first slide of Professor Venkat Raman said is that health is a state issue. It is not a center's issue, it is a state issue. The state is the maibab of keeping the people living in that state healthy and happy. But today, unfortunately, if you see the structure of the state, okay, if you see the health department, there are no experts. Like in Maharashtra, from where I come from, during COVID, when we saw the structure, there is no person who is from hospital administration background or public health background who can take calls. So without the right mix of the right experts, how can you run a state health system? So the basic, see, because I'm a nurse, I look at the anatomy and physiology of a person. In the same way, I look at the systems also. So if your anatomy is not proper, if your structure is not proper, if you don't have people, your policies, the last policy or the last job description which I referred during my PhD was in 1960. That book was. So from 1960, they have not upgraded the job descriptions. Okay. So if your little bit of healthcare structure, which is 30%, which the public health system is delivering, if that is also not placed properly, structurally inclined to give proper healthcare system, so from where, how can you deliver a good service? Okay, so the whole part is there is no structure. How will you govern the private sector? There is no governance. There is such a misfit. Okay, what is governance? Governance is taking care of the whole system which is there. So if you, and in the governance, you need people, you need systems. Today, if you see any healthcare structure, okay, at the state level or at the ministry level, there is no proper structure. There are just programs. And in the programs, there are people, but there are no systems. We don't have dashboards. We don't have connectivity of computers to the primary healthcare center, or forget primary, civil hospitals are not connected. We don't have dashboards. So when the COVID struck, okay, the reality came on our face of the improper or collapsed public health system. At the same time, we saw the private healthcare system was not prepared to take so much load. They were prepared to take 200 beds hospital, can take certain amount of load, but they cannot take the state's load. Okay, we being from Mumbai, we had maximum intensive care unit beds, but still we fell short. So somewhere we have missed the bus. Okay, because again and again, if you're going to tell me that we have to increase the beds, how many beds will you increase? Why can't you change the narrative? Why can't you work on the NCD cases to reverse diabetes, to reverse hypertension? Why can't you use the public-private partnership to change the models of the healthcare system on keeping people healthy? You can earn money by keeping people healthy. Why you want to earn money by doing cardiac surgeries or doing knee replacements? You give that person good environment, good healthy garden where he can sit, walk. You look at the senior citizens today because of COVID, they are depressed. Maximum of them are trying to commit suicide because they cannot get out of their house. So why can't we change the narrative, redefine the whole policies? Okay, the directions of the policies have to change today. We need policies for healthy senior citizens, healthy children, healthy mothers. We don't require policies for diabetes, hypertension. I'm sorry. There will be n number of diseases because pharma company has to sell their business. So they will make more 200 diseases. Okay. So, there will be so many other components which will come in. Like today, you see not only pharma companies, you see the companies, diagnostic companies. New models are coming of diagnostic. Do you really require a CT scan every year? I'm sorry. If you're healthy, you don't require it.
Absolutely, sir.
So I feel somewhere there is a change. There is a change happening so fast. Okay, so the challenges are happening so fast, and there is a threat to our health, and it is a threat to the community and to the nation today. And this whole thing, we can only come together as one community, involve the community, involve the mother of the child in taking care of the case. Just by giving a pill, the child is not going to be okay. The child is healthy, and if the child has enough energies to become healthy back again, the child doesn't need your syrup. The child needs good water, good food, good children to play, good garden. So I think we have to redefine the whole concept of health. We have to redefine our curriculum of hospital administration and public health. We have to redefine doctors. Doctors don't know how to take care of transgenders. Doctors don't know how to take care of geriatric cases. We all have senior citizens in our houses, and they have issues which are very different, which are more psychological and emotional. They don't require your pills. You see, every senior citizen is having more than 8 to 10 pills. Hypertension, diabetes pill, then a pill for thinning the blood, okay, multivitamin pill. Why? Do you really require? And the same senior citizen, if he goes back to his villages, he doesn't take any medications and he's fit and healthy. So I think the whole redefinition is required. Reframing is required. We need new concepts, okay, with different lenses. Okay, you have to use a lens of human rights. Health is a human right. It is a right. You cannot say that, if you're not paying, if you're not having Aadhaar card, or if you're not having certain things, I will not give you healthcare facility. I'm sorry. So I think that today, the whole structure, the government is responsible to run the country. So while running the country, the first important thing is education and health department. So they have to invest. Without the commitment, without the political will, and without the demand of the people for being healthy, you cannot bring change in the whole system. Okay. So today I think that we need private sector and public sector both to come together. Okay, and work on social determinants of health, economic issues, gender issues, okay, and come to a consensus with the ethical principles, that is of universalism, justice, dignity, security, and definitely human rights. And this approach will be a valuable service to the humanity in realizing the dream of right to the health. I think that is the most important narrative we have to do. The ultimate yardstick for the success would be if every Indian from the remote hamlet of Bihar, okay, to the never sleeping city Mumbai, okay, they experience the change.
You can cut short, please.
Yes. And
You can cut short, please.
yes, I will cut short this part. And I feel that the whole direction, we have to redirect the policies. We have to redirect what type of hospitals we require, what type of facilities we require. We have to redirect also on what type of human resources are required. Today, if you see the human resources in healthcare sector has changed. Okay, home healthcare has come in, telemedicine has come in, but we don't have people there. So I think the colleges or the education system for the healthcare system has to rework on it. And I think public-private partnerships should work on these important issues. And I would like to end my whole session is with one thing, that today we all have to come together as a nation, and we have to demand from the government that we want healthy policies, fresh air, fresh water, good food, and accessible healthcare facilities to remain healthy in our country. Thank you very much.
Thank you, Dr. Swati. Thank you so much. Very interesting and provocative perspective that you have and presented over here. The very interesting point is the narratives to be changed. And to change the narrative from what is called the treatment to making people healthy is a food for thought for every one of us, especially those who are in this particular discipline, and how really public-private partnership could really fructify this kind of a change of narrative from what is called the treatment philosophy or the treatment ideology to what is called making people healthy. That is something, the message that I could understand or get from Swati's presentation. Thank you so much. May I invite Dr. Gupta to share his perspective and reflect on Professor Venkat Raman's deliberation.
Am I audible?
Yeah. Dr.
Yeah.
Gupta.
Okay, so thank you, IMPRI, and thank you, Professor Sunil Ray, for asking me to be a discussant on this very eloquent presentation made by Professor Venkat Raman. And he has thrown up so many issues that it's impossible for me, because we are 12:54 already, so 6 more minutes left to wind up, as I understand, to this webinar. So I'll just make a couple of points. One important point which I want to make about the PPP is that within the private sector, we really have to make a very clear distinction between private sector, which is for profit, and a private sector, which is not for profit. These are two very clear distinction, which I found somewhat blurred in the presentation, and I had could lead to lots of confusions. As far as if I could call it a PPP, then perhaps we were the first organization, Prayas, way back in 1982, December. We were handed over a primary health center in district Chittorgarh to run for almost 3.5 years. And after that, there was another organization called Search, led by Dr. Abhay Bang, which was given a district hospital to run. And we both had to hand over these institutions back to government for reasons not of the funds, but certain other reasons. And what I wish to tell is this, that we can always call that private sector, because private sector exists in India. So it is not going to go away even if we wish. The other thing which very important, Dr. Venkat Raman showed in one of his slides, was about this global picture. And what struck me was about the total absence of private health sector in entire continent of Africa, which was something more very clear, stark illustration of the fact that private sector goes only in those areas where there's money, people have money to pay. It doesn't go in those areas where there's money, no money to pay. Now, as far as the engagement of private sector with the public sector, I have seen all kind of engagements, different kind of combinations, permutations, everything I have seen as far as these kind of engagement. Of late, the Niti Aayog, in fact, floated on a scheme in which they wanted that in tier 2, tier 3 towns of India, the public sector, means the district hospital, should carve out about 50 to 100 beds for setting up units of cardiology, neonatal cardiology, neurology, and oncology by private sector. Not a single private sector came forward because they didn't find it profitable enough. So the objective of the private sector for profit is private sector for profit is profit, because that is what they want, they could exist on. And even if what amount of regulations you put on them, they still would have to exist. If you put lots of regulation on them, then why should they remain private sector? Then they very well get into the public sector. And that is what began to happen in US. When Obamacare was enacted, people began to, finish off their private practices and began to join these network hospitals. Essentially, because of this reason, because they found that it is not going to, they can't make the kind of money which they were making. And once the Obamacare was dismantled, then again they began to move out from those kind of things. So this is very, very clear. And as far as preventive healthcare is concerned, primary healthcare is concerned, private sector for profit would never ever get into it unless otherwise. The other problem issue about the private sector is that when public sector or the government system wants to engage private sector, they have to have equal opportunities for the entire private sector. So they have to float tenders for it. And when they float tenders for it, the one who bids the lowest is the one who gets it. And once who bids the lowest gets it would certainly be cutting corners. In the sense of, making such all kind of things by which that entity could provide the least possible services, because in order to save, money. This has happened in cases of all these, big private hospitals and these huge, big private hospitals given land at a subsidized cost. And they were asked to, treat about 10% of these economically weaker section people into a free or something of this kind. And none of them were doing it. And when some began to do it, you could see that they created a separate ward for these people who are coming from EWS. And then again, they were cheated. So they were double payments. Payment in the sense of that government has subsidized and they are showing it to the government that we are treating them free. But they are also charging them for certain things, that this part of your treatment is free, this part of your treatment is not covered, so you have to pay for it. And the same thing exists because now the government has come out with the newer systems like this ABPMJ or earlier RSBY and several insurance schemes which are coming. And everywhere you hear the instances of double payment, 3 payments, 4 payments. I chaired a committee very recently on ABPMJ and HCW where there were representatives from ABPMJ, means National Health Authority, and these guys were telling us that there have been several instances where we had to, get into and recover the money. So I think about 12 crores so far. They got back money from these private institutions and paid it back to the patients from where they had charged. So this is the kind of a situation we are into. And I have my all kind of reservations in terms of that public-private partnership could really become a reality. In fact, the more important point is that how we strengthen our public system. And the public health system would strengthen only when especially for the area of public health, when all these foreign institutions like World Bank or all these Rockefeller Foundation or Ford Foundation, and all are thrown out and do not have any say into all these matters. And let the people at the grassroots conceptualize that how they want to fix. I interact with medical officers of PSC on a daily basis, and I find that most of the medical officers have no idea about the public health, and they are completely all the time burdened by these policies and programs thrown up from Delhi and international institutions. So they need to close down their shops. They need to, if given the choice to me, I'll reduce MOHFW, Government of India, from what it is to 10% of its size. Then only things will begin better. Otherwise, it's not. So thank you very much.
Oh, Professor Dr. Narendra Gupta, so interesting your deliberation is, and perhaps the opportunity is there. I would request IMPRI to organize a full-fledged lecture by you to be delivered, because because of the time shortage of time. Perhaps you have got many more things in your mind to share with the public or the people like us. But definitely to contextualize your point of view is something very important. The task for IMPRI and us to see how this could be related to the whole central theme of the presentation of Professor Venkat Raman, the partnership, public-private partnership. Yes, I do agree with you. And of course, Professor Venkat Raman may not have much of disagreement with you on certain aspects. But the point is that to what extent this partnership and where this partnership would really fructify at no cost to the public. This is a question that needs to be addressed. Is it possible? Is it feasible or not feasible? That's another question. The question is the possibility, feasibility, and something which is contextually relevant that need to be discussed and thrown out and discussed amongst all of us. Now I'm leaving it here, but I really felt enlightened by sharing your experiences, being in the part of the committee as a chairing, or have been working with the people, very closely in touch with the people day-to-day living, and all that. Very briefly that you have spoken, perhaps you have got many things to talk about. Anyway, I thank you so much for your deliberation. I thank Swati ji also for a very interesting perspective that she has shared. Now I am leaving it to the people who have been participating in this deliberation, in these discussions, to raise questions or share the perspective or reflect on what Professor Venkat Raman has spoken about. Thank you so much. Now I'm leaving the floor open for discussion. Anybody wants to raise any question?
Sir, I will collect the question. Professor Raman has also tried to answer some, but sir, Professor Raman, would you like to reflect upon what Swati ma'am and Narendra sir has raised? Would you like to?
Quickly,
very interesting.
Don't give me the opportunity again. Quickly, I think I think both the discussants have made wonderful comments. First of all, to reflect upon what Swati is mentioned about, I think somehow we tend to focus on the system, the procedures, and we somehow tend to forget that at the end of the day, it is the patient centricity. I think if you keep the patient in the focus, or if you keep I wouldn't even use the word the patient, but the care seeker in the forefront of everything, rest of the things can be designed. I can only give just an example of what we did with the National TB Control Program when we were designing the new guidance document on the private sector engagement. We just followed the way that the patient would seek care from a private provider for TB care. And wherever there are intersections for private sector to be engaged, we went about doing that rather than looking at, shall we develop a guideline? Can we develop a costing? Can we do the other things, etc. It's very important to keep that in focus, as Dr. Swati mentioned. I think the point that Dr. Narendra Gupta ji mentioned about is that there are several hiccups that do happen when we engage with the private sector. What I mentioned in the later part of my presentation is that the foundations on which this should be built. You know, you can't actually jump into a well if you don't know how to swim. This is the kind of language that I use with people who criticize PPP. PPP is not wrong. Private sector engagement by conceptually or by any logic is not wrong. But if you implement it poorly, if you are not capable of handling a private sector contract, which most of the health department officials are not trained to. I don't blame them, but they're not trained to do that. So when you are not in a position to handle it, then don't blame that PPP doesn't work. PPP has been working, and it's been working all over the world. It's unfortunate that there is a lot more, what we call it as a mental block for, you know, keeping the private sector engagement as an opportunity. We always tend to think that when we open up the private, PPP, the private sector will be in the, queue for, knocking at our door, which Dr. Gupta mentioned very clearly. The private sector can do their own, business on their own. So the question that we need to ask is, who's more desperate for partnership? Is it the government or is it the private sector? In this case, in Indian context, to a great extent, it is the public or the government which needs to be seriously exploring the private sector option, not the other way around. And to mention about Dr. Gupta's reference, sir, I did mention about NGOs, but I did not explicitly mention that the private sector can be categorized as for-profit and not for-profit. But that's more of a theoretical, conceptual grounding. But today, what we have been doing is that we don't encourage any L1, that is the least bid the people. We are using the word called QCBS, that is quality and cost-based screening. So in that sense, a lot of private sector people who are not good enough technically can be screened out.
Thank you. Anybody else?
Yes, sir, there was one question on the chat box, which Professor Raman has replied also. Can a statutory reservation for honoring the payment to private players in PPP model is feasible and constitutionally valid? And sir has replied that the contract needs to be amended, which they have done successfully in UP lab service contracts. And time and again, this question is coming. Let me only pose few questions, starting with this only. And so how do you see the bureaucrats or the relevant people to be penalized, or what lever should we have to improve this delays payment mechanism? Right. And also in the procurement, we see government offices then stuck in only that thing only, not into the welfare. And time and again, we are saying that the capacity building and human resource training and everything happening. What do you see the way forward? Another question which I really wanted to ask you said that since this century, we have seen there was school deficit in the education sector, and that has ramped up substantially, but that has not happened to the health. In fact, when I am a housing researcher, so when I see the number of colleges and schools which comes with the decennial census, the health sector has really not picked up. What do you see the reasons behind that? And is there a huge demand in future to come in your assessment? Another question, which I thought as a policy and in your experience, we have National Food Security Act, the PDS, and we are claiming that we are giving free food, free ration to 80 crore of the population. How do you see the coverage of our health, Ayushman Bharat, the insurance scheme, because our public scheme also caters to the poorer section of the population. Do you think that AYBM will go up to 80 crores, and how do you see that it also percolates to the middle class as a practice? If we are saying insurance is a practice, does now it is the time that we experiment something for middle class, give some concessions so that we have wider coverage of insurance, especially after the pandemic? And in terms of the private sector, sir, which you asked, you suggested, there are also, whenever we are talking about health or these things, the big tenders comes in fact, and that is, not very sacrosanct, then everything permeates. Same for the vaccination, what we saw, the private sector coming in. And then we see, then there is also kind of monopoly of the organizations, big corporates, or even in research we see then American consultant J-PAL and other comes, and when you see the recommendations like 4 lines, very basic, nothing comes out of all the exercise. How do you see then the role of community or the local populace or intelligentsia complementing to that? And one last question, Professor Raman, I really wanted to ask. Now we have 1.5 lakh health and wellness center as a target under our NHM. And time and again, we are saying, whenever we change the program or anything, we have around 10 to 15,000 SWCs, which are effective, and we show them. What do you think is stopping this scale part, especially in the health sector, for a good delivery of healthcare, especially what we witnessed after the second wave?
You have got so many questions,
Come on.
Professor Venkat. I've been able to record everything. And then,
I will repeat.
All right, I tried to note down some of them, but if I am misfiring, maybe you can remind me. Bring me back to the,
He spoke.
yeah.
So anyway, to the extent you can, and then particularly some of the points which he did, I could follow 1 or 2. He's very fast on all that he spoke about. This MNCs and all that, and the price and the control over the market and control over everything. So the last points he was making, and earlier point that he made about that whatever extent that he could make out, please respond. But each and every point is, and if it is not being answered, I request Arjun to repeat it. So don't put all the questions at a time. It will be too difficult for him to answer. You need to be enlightened, but each and every question is very important. So let us say 1 or 2 questions first.
Okay, I think the first question that I would address is the first question to begin with, that is about the payment. What we have done in some places, especially the way that we designed a contract in Uttar Pradesh under the World Bank Health System Strengthening Project, is that, and this is something that I keep advocating, if an official is to clear a payment, that official should have only 5 days to clear it, in the sense that if the person doesn't have any objection to the bill that has been raised by the private provider, it automatically moves to the next desk. Penalizing is one part, that if there is a delay of, let's say, 30 days or 60 days in the payment release, you can do a bit of either you can penalize the system by saying that outstanding amount should be accounted with interest payment, but then the official concerned doesn't care in such kind of a system, because it's a system that's going to pay the interest. The second option is put the onus on the official concern, that if it is staying there for more than 1 week in your desk and you are not making the file to move, then you will be liable to bear the cost of that delay. But to do that in a reverse way, in a more positive way, is that it is assumed to be cleared if it is delayed by more than 5 days in your desk. So that will, then after 5 days, it moves to the next, authority. One of the most important element in this is that payment, the entire verification and the payment should be using the IT backbone. If you don't do that, manual payment, as long as you have the manual payment, there is always a possibility of kickbacks being demanded and kickbacks being given. And that's the bane of payment. If I delay the payment by 1 month, the private partner will become more desperate, and therefore I will ask for 10% and he will be forced to pay. But if I put that everything into IT system, including the verification and the validation, then there is an automatic non-human interface in the entire payment system. And that is already in practice in some of the places that we have been working. So there is a solution to that, it is not something that is, not possible to resolve. I'll take the third question as the second question here to answer, related to Ayushman Bharat. I see that one of my friend here who is part of the National Health Authority, also a participant. He can also vouch for this. Every health insurance operates under the notion that there is a pooled risk. The meaning of that pooled risk is people who are healthy, people who can afford a greater premium, can cross-subsidize the low income, low value treatment, etc. Till the middle class like us become part and parcel of the Ayushman Bharat scheme, it will then continue to be social health insurance, wherein the government will have to put the majority of the payment. Health insurance per se cannot rely only on government alone assuming the risk. It should be the collective risk shared by the population. You take any of the developed countries, whether it is NHS or whether of the UK or Canada, you will see that this kind of risk, pooling, and that's what makes them to be as good as they are. We have a long way to go till we come to that particular stage. But having said that, Ayushman Bharat is the path breaker. In that path breaking, I mean, when you are trotting for the first time, you are likely to have all kinds of barriers. Learning, improvising is something that Ayushman Bharat has to institutionalize, and in order to really make this to be the most successful program anywhere in the world. Third question is about the fifth question that I'll take as the third one, health and wellness center. The health and wellness centers are very well concepted in terms of, unfortunately, for a very long time, we have looked at the primary health centers in rural areas as Nasbandi clinics. You go and ask anybody in the rural area, they will tell you that primary health center to Nasbandi clinic. Because our focus was so much on family welfare and reproductive health. All other remaining clinical services had taken a second seat or second, sense of importance. It's important to revive this notion of health, not just population control, should be the focus of the ASHA worker or ANM. The ASHA worker, even today, is seen as someone who promotes only condoms and birth control. That image must be kind of a reinvented, and therefore creating this health and wellness center and including the screening for non-communicable disease is a most welcome step. But then you need to again create that kind of infrastructure, the screening process, the capacity building, the resource allocation, all of them are important. So we need to create that financial allocation to those health and wellness centers in order to make this a success. The next is about the research. I will not comment about that because yes, there are very large scale evidence generation that we ourselves need to generate within the country. Unfortunately, still till date, our own research funds are so minimal. For an Indian researcher to rely upon Indian source of funding for research is so poor, and therefore I don't know how long this is going to rely upon, unless you go for some international funding for research. You don't have that kind of a scale and the kind of a need for evidence to be generated. I think Department of Health Research and their ICMR are from the ministry need to really attend to this. That's what I can at this juncture say. The last one is about the school. In PPPs and private sector in school systems have been predominant. But I do not know whether healthcare can have very similar kind of effect. But healthcare is a matter of life and death. I see that there is a lot of hypocrisy, if I were to use a very strong word, hypocrisy, when we talk about the private sector in healthcare. People who advocate the public health system in the public forums go to the private sector when it is their own problem. Okay, and this I see as a major barrier towards accepting that cohabitation, harmonious coexistence, complementing one another between the public and the private sector, that kind of a dialogue is needed rather than what the opening remark Dr. Sunil, Professor Sunil mentioned. Do you belong to that group or do you belong to this group? If you oppose private sector engagement or private sector, you are seen as an intellectual. That is not the kind of a discourse we need in our country. We need to focus, put the patient, put the people, and work around who will be at the best possible way to provide the services. Is it a community-based organization? Is it the NGO? Is it the private sector? Is it the government? The source of delivery should not be a matter of so much of a debate, ideological debate. I stop here.
Oh, then I make a point, a small point,
Sure.
Professor Sunil. Yeah, so the small point is this, that during this vaccination for COVID-19, something very interesting, which is, I think has not got into the notice of the people, is this, that about 25% of the vaccines were allocated to the private sector, which they could provide to anybody. Of course, they could charge also for this. So I don't know if people are aware of this fact that they could not utilize this 25% quota. In fact, the total number of people who got vaccinated by making payment were only the 4% of the 25%. Only 4%. What does this illustrate? What does this illustrate? I give it to Professor Venkat Raman to ponder over. It illustrates that only that 4% of the 25% are really the people who can afford private sector in this country.
Absolutely.
Everybody else, the figure which he showed about 60, 70, 80% people going to private sector, they are going under distress. We all know that 5 crore people slide down in poverty just because they spend money out of their pocket. So we should know that only 4% of the 25%, barely 2%, not even 2% people have that capacity that they can afford the private sector in this country. So let's not try to, blow private sector out of proportion in order to showcase that it has any magic thing by which it could take care of the healthcare system or the health challenges of this country. So this is what I wanted to say. I need to go because I am traveling. So thank you very much.
Thank you, sir.
That's a very beautiful.
Can I make a small suggestion?
Yeah. Go ahead.
I feel what Dr. Narendra Taji said, that we have to understand that India is still not a completely developed country. Even the developed country today are seeking healthcare from their public health systems. So why are we so much harping about the private sector? Because for past 30, 40, 50 years, we have always asked the private sector to come in to take care of the health of the country. And now we have realized that even in COVID, private sector, though it is 80%, it has hardly taken care of the COVID patients. Actual care of the COVID patients is being taken care by the public system. Public health system has taken. The COVID centers were made by the government of each states.
Absolutely.
So then why are we harping so much about the private sector? Private sector will come for profiteering only. These same private sectors have charged 14 lakh, 15 lakh bills because there was poor governance from the government. So you have to make your governance very strong. You have to make a cell. So in Maharashtra, we the civil societies came forward and we asked the government to reduce these bills, and we created the pressure. The public created the pressure on the government. That time, the state health minister went to each and every hospital and sat and did the accountings and the audits. So today, what we need is the social audits. The civil societies and the community participation is needed strongly, and there should be budget for that. The union health and the state health ministry should create social audits budgets. So there should be separate budgets for these audits. There should be separate budgets for development of the public healthcare systems. Today, if you're going to give the civil hospitals to a private healthcare, they're going to run it like a private healthcare because their intention is to bring the frills, not take care of the patient.
Absolutely. Yeah.
So why do we need the frills? We cannot afford the frills. Let us concentrate on the quality care. They have so much good systems in the public healthcare system. Why not create those programs? There are so much of quality being done. There is so much of programs which are done like for TB and all. They have helped us. But the only problem is because there were no proper people there and no proper budgets. That is the reason they have flawed. So I feel that we have to harp more on creating this good, strengthy public healthcare system today in India, not the private healthcare sector. Let them come in for certain areas. We cannot do without private healthcare sector, but we have to be together. But more 80% should be the public healthcare.
Good.
And Dr.
Just a quick comment.
Professor Venkat. Okay. Anybody
Just a
else?
quick comment. I don't want to take.
Yeah. Why not? Why not? Please.
I think the corporate hospitals that we are we are categorizing as the private sector is only about less than 5%. Apollo's, Fortis, Maxes are very, very less in number. But a large segment of private sector are either individual units or nursing homes or polyclinics or small tier 3 level or tier 2 level hospitals with owner-funded, owner-operated kind of establishment. This is what we are talking about as the private sector. We're not talking about the Apollos. Apollos will come with the infrastructure-oriented, sure, profit-making. But the profit is, what is the word profit? Who defines this profit? Who regulates this profit? We cannot put the onus on the private sector if the government fails to regulate them. The government's responsibility is to regulate. So I'll stop there. Okay.
Yeah.
We need good regulation. There is no regulation today in our country for the healthcare sector. So we need strong policies first. Yes. And the mechanisms. After that comes the mechanisms, then the social audits. So I think that framework should be first defined.
Absolutely.
Okay. Way over time. Would you like to conclude?
Yeah, I like to conclude, but before that, I have a small question to Professor Venkat. Very, very simple and small. I just want to know, Professor Venkat, PHC in the rural areas. As I mentioned in my opening remarks, the 73% of the latest estimate of the rural population do not have what's the PHC, no access to PHC. Fine. It's a fact. Let us not repeat it. Now, you are an expert. You have been working in this area for a very long period. Have seen the world, have seen the countries. You also come from the village, as I come. Now, can you please tell me or tell us any PPP model could really achieve success or have been able to succeed in the rural areas to create successful PHC? One example, two examples is a model through PPP. This is my question. Second one, yeah, that is the only question. Yes.
So I
Can you
did,
please tell?
yeah, I did mention about just a given example in one of my slides about the success of NGO-based or NGO-run primary health center in Karnataka. And there are these kind of stories are there in almost every state wherever primary health center. For example, in Odisha, for example, in Arunachal Pradesh, for example, in Andhra Pradesh. So there have been examples of NGOs running the primary health centers, running the community health centers, and doing very well compared to the government's own management of primary health centers.
No, 1 minute. 1 minute. Here, there's a problem here. And in the initial remarks, you made it clear the NGOs or civil society organizations on management is different from the private sector, who are essentially looking forward to have profit. Their whole philosophy is profit over people. But the civil society organization, people over profit. You see, let's put it this way. There could be distortions here and there, but basically this is what is talked about. Now, for example, Prayas, Dr. Narendra Gupta's organization, and they have been working in rural areas for more than, 1960 onwards. Okay, now they are putting forth for the people and they have been working with them and working in tandem with the government, have been providing services, and they're well known in the entire area, not only the common public, but the tribal area also. Now, and he did not speak much about it, but I know personally they have been working. Not that everything is hanky-dory, everything is perfect. There could be some problem here, but 99% cases we find that they have a success stories. Now that is a collaboration between the government and the NGO, and you're talking about the Bhubaneswar, the Odisha, Arunachal Pradesh, but I'm talking the typically private sector having partnership with the government, working in the rural areas, reviving the PHC, working, functioning, managing very successfully. Do you have that kind of thing?
Let me first of all comment on people first and then profit later, or profit first and people later. These are some of the terminologies that I don't really have much comments about, because I know that Swati runs the private sector, and her approach towards patients are customer centric. She is not using the word profit there. Every private sector profit also would be thinking about customer retention. So they wouldn't, one wouldn't say that it is profit first. And
sustainability is also very important.
So then comes the question about what you have asked, whether private for-profit have done anything better in the rural primary health center. Now the question that one need to ask is, would a for-profit, something like a Fortis or an Apollo, be interested in managing a primary health center which has a budget of 25 lakhs, when they would be handling something like about 100 crore per annum or 200 crore? Why would they be focusing their energy into something which is just about 25 to 30 lakhs worth of a issue? One did not challenge, we don't know yet. One perhaps can challenge the for-profit people if they can be given 100 primary health centers, and why not run it, which would have something like 25-30 crore kind of a value. So the word that Swati used about whether it is sustainable, is it value for money? Do I spread my resources too thin in managing something that I don't get any kind of a margins? The second more important problem is that NGOs operate under certain kind of a shoestring budgets. For profits, they are already in the market. The word market is competitive. So would they be able to really get that kind of a staff and the resources or the equipment, etc., given the kind of a budget that is very nominal? that an NGO offers? So these are some of the broader questions. I will not get into this at this juncture because these are much more fundamental issues.
And healthcare is a service oriented. So for service, you need more of human resource, and human resource comes at a cost. And this human resource is a skilled human resource, which are registered doctors, registered nurses. So we need skilled and qualified people in healthcare. But today, if you see in the private sector, this is compromised. Not all nurses in the private sector are qualified nurses or registered nurses. So if you are not going to have qualified and registered doctors and nurses, you are in a danger. And are you ready for that type of danger? So that is a big question you have to ask to the government, because government's political will and budget is the most important key factor today, which is lacking.
Very important, yes.
And
now,
so by government,
shall I conclude now? Shall I conclude now?
Yes, yes. And by government, we are giving to ANM and ASHA 3,000, not even on time.
Yeah, 3,000. You don't give to your maids also. Your maids are taking 10,000 rupees.
Right.
Your driver is taking 20,000 rupees. And look at the skill what ASHA has or a nurse has, and the qualification and what responsibility a driver and maid has.
Right.
So I think, somewhere structurally and fundamentally we are wrong as a country. Okay, so we have to create that clarity from the government. I think that is the most important thing. There is a fundamental issue.
Yeah. And the question is that, suppose, shall I conclude now?
Yes, sir.
Oh,
lunch time for everyone.
Yeah, I know that. Actually, I'm also inclined to ask many questions, but well, I'll stop over here because always I was thinking that, now wondering this, public, I'm coming back to the same issue, which I've not been able to satisfy myself with I was expecting Professor Venkat to be able to react more and to show some examples of the kind in the rural areas for PHC, which is very vital issue of the health care center, health for the people, the 73% of the population of the country live. And in that situation, you do not have such partnership, successful partnership. What is that you are talking about? What is that you are talking about, sir? Are we really on the right track? I do not know. But anyway, leave it.
Do we need a private sector in the primary care?
No, I'm not talking about the profit. The question is that let's forget about the profit. Let us forget everything. I want to see a model, a public-private partnership, sir, in rural area, which is successful for PHC. How many are there in the rural areas in India? Where they are? I will have to conduct a study on that. Are there any? Let us see, find out. I think as far as I could understand from there may be few here and there. Not that type of private. I'm not talking about NGO or civil society organization or Seva Kendra or some Brahma Kumari or something like that. I'm not talking about that type of organization. I'm talking about purely private. And that private sector which has flourished in the urban areas in India are collaborating with the government and then able to, start up PHCs, making very efficient delivery system and all kinds of things, and people have access to that kind of thing. Access and proper pricing. Is there anything of that kind? So certainly we are short of such kind of answers, and perhaps we will be able to investigate, we'll be able to know more about it later on. But anyway, I'll stop at that. Now, I thank, let me conclude, since I have been moderating. It's a very exciting and very important deliberation being given by Professor Venkat. At the same time, I must thank also Dr. Swati and Dr. Narendra, to have really given a very thoughtful presentation as to how to go about it. We do have the contrasting views. Of course, we do have and do continue to have this one. But what are the issues that come up? Is there anything new thing that you are talking about? I am questioning myself after hearing. Is it the same story that we have been hearing for last 10 years? Or perhaps the next 10 years we'll be hearing the same stories? Are you going to make a change of the stories? No, we have not been able to make it. And this is the kind of debate that has been going on for quite some time. And, it's kind of thing. Now look at, just for example, all of you know, we need to learn from some of you. Look at a small country, Cuba. A Cuba. Now, what has been the healthcare system of Cuba? The country which is facing 60 years of sanction for the US government. But despite all the difficulties, not a rich country, but despite all the difficulties, not only they have ensured 100% efficient in healthcare system for the majority of the poor, but also they have been delivering the services to the rest of the world. And medical cost student is too low for to become a medical graduate. And they are delivering the services to many people of the world, many countries of the world. Maybe earthquake, maybe COVID-19. In Italy, COVID-19, continuous help they sought from the Cuba. Italy is a rich country, but they sought help from the Cuba. And they have been delivering at a low price. It's a perfect solidarity of the humanism, of the human solidarity. How is it possible for that country to do it? It's the government sector. There is no partnership. And they could succeed. May not be very, there may be a country like us. But then they succeeded, we could not succeed. We are struggling. We are coming out with different types of schemes, varieties of schemes here and there, much more loaded with the politics than actually into what happens. Then, where do you stand? That is something we need to really think about. Then the question is that, do you want to commodify the health services? Is it not a commodification if you completely depend on the private sector? Is it, some people argue, that you are making the public sector weak to see that the private sector gets into the center of the entire discourse? Only thing became weak. But what Dr. Narendra was talking about, even Dr. Swati was talking about, if you make this system efficient, varieties of waste system can be made efficient. And you yourself said that in America, this is the kind of thing which is happening, switched over, switched on. No, Narendra was talking about. Now that's something which is happening. Now question is that to what extent you are trying to make the public sector very efficient as a delivery mechanism to see that something happens. Now, even if 75 years, 73% of the population in rural area do not have access to PSC, I think it is same on your part. Now, our revolution, our central point is that how to make it accessible. Is it through the public-private partnership, or through making efficient this public sector, or see the investment GDP? What is the total share of the GDP? Share of health sector to GDP, how much? And compared with the rest of the countries of the world, compared with some of the Latin American countries, small countries, much smaller than us, where do you stand? I think these are the questions that you need to see. And then who is making, yes, I do not disagree with Professor Venkat when he talks about partnership. See that where partnership is possible, see if it is not possible. But ultimately, as Dr. Swati was talking about, it is the responsibility of the state to provide what is called health care as a human right. You simply cannot say we cannot do anything. It is for the people, the government, it's for the market to decide. Even if you leave the whole human health to the market to decide to do anything, I think that's the end of everything. I don't think we can proceed. The civilization will stop over there. And that is the end of everything. I think that is what it cautions. And what Professor Venkat implicitly is talking about is this one. We need to find a way out as to how to go about it. We cannot dump everything like a private only for profit and therefore nothing. Yes, there are facts that the private sector also has been investing money. Now they would like to do something, business and all that, to see that, they aren't there, but then limit. The Dr. Swati is the limit beyond which you cannot go. What is the limit? Which is correct. You cannot really encourage beyond the point. And to see what are the weak areas If it is possible, is it possible? But if you go by what Venkat was talking about, Professor Venkat Raman was talking about, मंत्री जी बताया था ये बात को, पहले तो कितना रुपया मिलेगा, उसके बाद बोल रहा हम लोग को चूस रहे हैं प्राइवेट सेक्टर. This is the double role of the politician. If the politics has become like this, now question is the politics is like not become. It is like this. It is like this through which these private tenders are being called, through which the entry of the private sector, this is through which, and no matter whether the public are finally getting access to it or not, makes no difference. If it's this politics, then what do you expect from this politics? Schemes, different types of projects. Let these people go and they pay thousands and lakhs of rupees for a vaccination in the private sector. 4% or 25% being done. What is that to you? How do you glorify the private sector? It is eye-opening for me. I never knew that of 25%, only 4% being done. That too, under stress. Otherwise, this 4% would not have been there. People would have gone to the public sector. People do have the reliance, do have the faith, is the government, public sector can do the justice. Let us see this faith increases. Let us see that it is not eroded. At the same time also, wherever it is possible, as Venkat Raman was talking, Professor Venkat was talking, if the public sector cannot proceed with its technology, with its skilled people and whatever it may be, if there is availability of the private sector, we must really do. But see that there's something which is very important for us to do. You cannot really trade off on health between profit and people. You cannot have, this is something human, right? Let's begin and end up our argument on the health sector, on the partnership argument on this issue, that this is something human right, which cannot be undone. Thank you so much. Thank you all. Thank you all participants. Very interesting presentation. Very interesting, very provocative, intellectually stimulating. And both the discussions, Dr. Gupta and Dr. Swati, is very interesting. We really record. All this is being recorded. And I request Dr. Arjun to continue with this kind of flavor. It's a very important deliberation. I think this particular area, I request Dr. Arjun to really take off further and see that what few more deliberations takes place on this one. Thank you so much.
Thank you. Thank you so much, Professor Ray. And really to put forth a very short formal vote of thanks. So on behalf of IMPRI Center for Human Dignity and Development and CDECS, we thank you for joining our series today, the State of Development Discourses, #Cohesive Development. And today's special deliberation on lecture by Professor A. Venkat Raman sir on a very important topic, private sector engagement and public-private partnership in health service delivery in India. And I really find it very stimulating, as sir is also suggesting on key areas, or be it insurance, on the how pooled, and sir is also showing the direction and the way how the delayed payment and procurement things can also be enabled using IT technology. So some very elementary policy inputs there for really strengthening. And as Professor Ray was also mentioning that the amount of GDP, so it's so under, less at the mark. So I think it will multiply by several times. Of course, in Delhi or in Hyderabad, there is already health tourism and other things also coming up. There is also green picture, but so much so that all the panelists agree that we need a policy and implementation ecosystem so that all the participants, be it very huge, small cooperatives, they all can come forward. And as Professor Venkat Raman was suggesting, that the direction is right, and using technology, we can really harness this and leapfrog. So thank you so much, Professor Raman. It was really learning a lot from you today. And thank you, our discussants, Professor Swati Rane ma'am and Dr. Narendra Gupta sir, for adding to this deliberation, very stimulating discussion. And thank you, Sunil Ray sir, for moderating and chairing the session, and as always, getting us into this intense debate. Thank you. I hope you will tune into our further episodes of Web Policy Talk and Cohesive Development. Thank you, and please take care of yourself.
Thank you so much. Thank you.
Thank you, sir.
Pleasure meeting all of you.
Thank you.